All right, it is now 9 o'clock. So good morning, everybody. My name is Kelsey Miller. I'm the Social Determinant of Health Program Manager for Shield Healthcare, and I'd like to welcome you all to our webinar on Social Determinants of Health 101, Improving Patient Outcomes. I'm really excited about today's topic. Social determinants are an important agenda item, as many in the healthcare industry are recognizing that economic and social factors play a major role in individual and group health outcomes. Today's webinar will provide an introduction to social determinants of health and how community-based organizations like Partners in Care Foundation are implementing evidence-based programs to reduce healthcare costs and improve quality of life. Before we begin, just a few housekeeping items. Attendees will be in a listen-only mode. If you have a question, please type it in the question box on the right-hand side of your screen. There is also a PDF of the presentation slides that you can download. If you registered as a healthcare professional and are watching this full webinar, you will receive CE credits emailed to you from Capital Nursing Education within 5 to 7 business days. And if you're watching this presentation as part of a group, there are a few forms in the handout section of the webinar panel that your group will need to fill out to qualify for CE credit. This webinar will be recorded and available within 24 hours to view. And now we are honored to have Diane Davis from Partners in Care Foundation as our distinguished presenter. So Diane, if you can go to the next slide, please. Ms. Davis is Vice President of Health Self-Management Services at Partners in Care Foundation, leading 16 professionals implementing evidence-based programs. She has 25 years experience in the healthcare administration, managed care, and gerontology. Ms. Davis oversees federal, state, county, city, and private foundation relationships and partners as contracts for evidence-based programs with health systems. Ms. Davis holds a master's in public health from UMass Amherst and a postgraduate certificate in gerontology from UMass Boston. She speaks at numerous conferences, is a member of the Evidence-Based Leadership Collaborative, a mentor for the NCOA Network Development Learning Collaborative, and taught a course at UCLA entitled Evidence-Based Programs for Older Adults. Next slide, please. And here are the objectives for today's webinar. The first is, what are social determinants of health and why are they important? What is population health and risk stratification and why are these important? Why is it important for clinicians and community-based organizations to partner with each other? And what is self-management, and what are some evidence-based practices that include self-management skills? So thank you so much, Diane, for presenting this webinar topic, and I'm sure I can speak for all of us when I say we are very excited to hear what you have prepared. So at this time, I'd like to pass the presentation over to Diane. Thank you very much.
I want to thank everyone at Shields, and particularly shout out to Kelsey and Danny for all the work that they've done preparing this presentation with me. And I want to talk to you a little bit initially about Partners in Care and the work that we do in the area of social determinants of health. Our Partners has been around for 20 years, and we've basically been doing the same work for that 20 years. You know, there's been changes obviously over that time period, but our goals and objectives the whole time have been to work with the evolving healthcare system, developing and spreading high-value models of care and self-management. We partner with hospital systems, physician groups, managed care plans, and other community-based organizations. We've worked all along with a number of government agencies, but particularly in my area with the Administration for Community Living, which has all of aging and disability under it. And the work that we do there is deliver support to adults with complex health and social service needs and their caregivers and families. All of the programs that we do are evidence-based, and we've actually developed a number of programs here at Partners, including our Home Meds program and our Healthy Moves program. So what does it mean to be a specialist in social determinants of health? For Partners, what that means is that we're a think tank and a proving ground for evidence-based initiatives that work in this area, and we work to shape healthcare by creating high-impact, innovative ways of bringing more effective clinical and social services to people and communities. We've been a testing ground all along, so we'll develop new programs or we'll take on programs that have been developed elsewhere, test them, measure, try to make refinements to those programs, and then replicate them in various communities, whether that means different ethnic communities, different linguistic communities, or a disability community versus a general population. So we do that testing, and then we take those models and try to spread them across California and across the nation. The changes that we really are looking to see is the integration of medical care and social services, to see in the enhanced self-management and empowerment of consumers or patients, to see an integration of behavioral health, social services, and clinical care, which we call an integrated healthcare system, that we spread evidence-based interventions. And we, at Partners, have been one of the key community-based organizations across the country in developing a network of community-based organizations in the state of California in particular that can provide these social services as an adjunct to clinical services. And we're organized like an IPA, and we actually have 54 of the counties in California covered through our Partners at Home network. So this slide, I think, is a really important one when we're talking about social determinants of health and really getting an understanding of how the United States spends healthcare dollars in a way that's different from other countries. In the United States, about 50% of healthcare expenditures are made on 5% of the population, the sickest 5% of the population, and 21% is actually spent on 1% of the population, where we spend very little on public health, looking like much farther to the left on this slide, where other countries, as you'll see in the next slide, actually spend significantly more on social services and public health services, and then are able to extend people's time spent being well, and then they only have a short period of time at the very end of their life where they're spending dollars for the sickest in the population. This slide is really one of my favorite all-time slides because it shows the red lines on this slide are expenditures on social services by country, and the blue is expenditures on clinical care. And as you can see, a number of the countries on the far left, the European countries that have the best outcomes, spend 2 to 1 on social services to clinical care. And the United States spends about 55 cents in social services for every dollar spent on clinical care. And unfortunately, our outcomes put us 27th amongst nations, and that puts us approximately where Mexico is. But Mexico only spends 10% of the gross domestic product on both clinical and social services, and we're now spending close to 25, 26% of our gross domestic product on these same services. So we're not getting the outcomes that we would like to get for the dollars that we're spending. And there's a strong argument to be made that we would be better served if we were able to spend more of that money on social services and better integrate social services with clinical care. This is another look at premature death in the United States and what are the contributors to that. And I think everybody knows that there's a certain amount that's contributed to our health is genetic, and that's about 30%. Environmental exposures are another piece of the puzzle, and they account for about 5%. And then shortfalls in medical care. So whether or not you can actually, see a physician when you need to see a physician, or you have a hospital that's near you so that when you need an emergency service, you can get to an emergency room. But a full 55%, and this is actually fairly conservative. I've more recently seen diagrams that say up to 70% of the circumstances that lead to premature death are related to behavioral patterns or social circumstances. And by behavioral patterns, we mean things like smoking, lack of exercise, poor dietary habits, consumption of high sugar drinks, alcoholism, opioid addiction, and things like that. So again, Partners really works at this area where there's a connection between the healthcare system, the social service system, and the behavioral health system, which have all been separate in our country for years. And there's a real act now. One of our key terms that we use is the time is now, because there's a lot more media attention, and I think a lot more attention from the clinical systems on social determinants of health right now. And so we partner, and we hope you will also partner with hospitals and physicians and health plans, and really take our focus into the home and the communities where people live. 95% of a person's time is spent in their home or in their community, and a very small 3 to 5% of their time is spent interacting with the clinical system. So they really need to be able to take behaviors that they may talk with their clinical providers about. They really need to make those behaviors part of their life. We work with Medi-Cal, Medicare, and other private health plans, and we really try to work towards transforming Medicare and Medi-Cal. And Partners does that, but there's also, as I alluded to earlier, there's also now a movement towards population health. And population health is really taking a look at large populations and going through risk stratification, which I'm going to get into a little bit more further on in the presentation. But it's a much different way. Instead of doing units of care or providing widgets of service, a prescription for a drug, a prescription to get a radiology service provided, rather than looking just at individuals, looking across populations and seeing what we can do to improve health. So this is a pretty interesting study that was done by the Robert Wood Johnson Foundation on 1,000 primary care physicians, and it was done within the last 5 years. And what came out of that survey was that primary care physicians were really concerned about social determinants of health and how those social determinants of health were affecting the people that they were taking care of. 80% of the primary care physicians said that they weren't confident in their capacity to address their patients' social needs. 86% said that unmet social needs were leading directly to worse health for their patients. 76% wished that the healthcare system would cover the cost of connecting patients to services to meet health-related social needs. And 1 in 7 said that they really wish that they could give a prescription to their patients to go to a fitness program, for nutritious food, and for transportation assistance. And something that's happened just in the last few months or the last year is that now Medicare Advantage plans are going to be allowed by CMS to provide some of these services. And they won't have to provide it. Generally a managed care organization has to provide any service that they provide or allow one patient to get, they have to be open to providing to all of their members. And CMS has said that now if there's a particular need in order to keep someone healthy, that they get a nutritious diet delivered to them for some period of time, that the managed care plan can provide that coverage. Or if in order for them to get to their physician's appointments or to get to other types of critical appointments for their health, they need transportation assistance, they'll be able to get that coverage. So that's something that's going to be new as of 2020 for Medicare Advantage plans. And I think many of us who have worked in the healthcare system for some period of time know that where Medicare goes, often other plans will also pick up those benefits and provide them as well. So this is a key outcome that it's taken a number of years to get to, but it's a very positive for addressing the need for social determinants of health. So here's the slide beginning to talk about population health and how this is a new role for medical systems. A lot of, in California at least, and I also know on the East Coast that a number of large healthcare systems now have a department of population health where they can take a look at the data that they have on the patients that go through their system, and they can look at folks that have diabetes, or they can look at people who have COPD, and they can monitor when there's trigger events that occur in a particular population. For instance, when somebody that's been diagnosed with diabetes first gets put on metformin, they can see that as a trigger event and perhaps have a case manager or somebody in the population health department reach out to that patient and say, you know, would you like to go to a diabetes self-management program or for diabetes education at this particular moment where that member may be more open to learning things that can help them control their chronic condition. So risk stratification is really looking by diagnosis or by cost at a segment of the population that you're taking care of and screening and targeting interventions for that particular group of individuals or people with that particular set of diagnoses or circumstances. Then these trigger events, the ones that we know the most about are when people are first diagnosed with something at a time when they move from a lower level medication to perhaps a higher level medication, or a second medication is added on. They tend to be more open perhaps to hearing other things that can be done to help them monitor or control their disease. Also a hospitalization or a visit to the emergency room. These are times when people can be more open to hearing about other things that might be able to help them control their chronic conditions. And so we try to build comprehensive partnerships with community providers so that at these trigger events, or if there's a program, if you're doing a risk stratification and you're looking at a particular population, you may know that you'd like to have your diabetes population go to a diabetes self-management program or go to diabetes education. So if you work with a community provider that provides those types of programs in the community, you can make it easier for your population to actually receive the services. A lot of times people are more comfortable depending upon what population you're working with. I know we work a great deal with a Medicaid population, and a lot of times they tend to be more comfortable going to programs and going to things that are going on in their community rather than having to go back to necessarily some other, large organization that they perhaps don't know that well. So I'm happy to take any questions that you may have on this, because this is one of our key outcomes that we want you to understand, is sort of population health, risk stratification, and how those trigger events can open people to going into new types of education and self-management. So community-based organizations really are the bridge to the home. We've worked to improve people functioning in their communities and at home for decades, and that's not just Partners in Care. That's true really for all community-based organizations. That's really what they've been doing in the community over their existence. There's a deep trust that many community-based organizations have with the populations that they work with. A long history. They're culturally and linguistically sensitive organizations. A lot of times people that work for these organizations actually live in the community where the work is being done, so people will know them perhaps from their faith-based organization or other relationships that they may have through schools and other things that they do in the community. We tend to be pretty flexible. You know, we're small and we can move quick. Doesn't take quite as much as it does to turn the boat in a great big healthcare organization. I worked in a 9,000 employee healthcare organization on the East Coast for a number of years, and to make changes there definitely took a lot longer than what it does at Partners, where we hover around 100 to 120 employees. We also tend to use a lower level of professional employees, so we'll be using health coaches or navigators, social workers, or community health workers. So we have a more affordable workforce, and there's a lot of things that we can do that then allow for professional nurses or physicians to work at the top of their licensure, which saves money in the system for all of us. So here's the full range of services that we offer at Partners. We have long-term support services, which is down on the lower left hand of the slide. These are really tend to be Medicaid waiver programs in the state of California. We have an MSSP program. We actually have 4 sites now, which is a nursing home diversion program. It's a program to allow people to stay in their homes who would otherwise have to be placed into a nursing home. They have long-term case management, and they can stay on with us for as many as 5 or 6 years. We also have the California Community Transitions Program, which is a repatriation out of nursing home program, which provides them the same types of supports to keep people in their communities. We also then have on the lower right-hand side our short-term in-home services, our Care Transitions Program, which is a coaching or telephonic social work support program for people who are being discharged from the hospital, and we'll go into the home, do a medication reconciliation through the Home Meds program, which we've developed here at Partners in Care. We also do a psychosocial and functional cognitive assessment. We'll look at home safety and falls prevention within the home. But these programs are generally short-term. They can be anywhere from just doing the assessment in the home to doing the assessment plus 30 days after discharge, keep making sure that the person is reconnected to their primary care provider, seeing if perhaps they need assistance in getting connected to other kinds of programs that they qualify for, or finding if it's 110 degrees in the San Fernando Valley after you've been discharged from the hospital and you don't have any air conditioning, we might be able to connect you with programs that can provide you with services so that you can get that air conditioner you need in order to stay healthy, or you can get meals in your home. And then finally, there's the programs that my area is responsible for, and that's the health self-management programs. And that's what I'm going to talk about in a little more detail for the rest of the presentation. The population that we target for these health self-management programs is really at the teal level of the triangle. They're chronic conditions with fairly mild symptoms. People, maybe on the first level of medication, they may not need medication yet. Or they can be a little farther up into having chronic conditions with mild functional impairment, and a lot of our falls prevention programs would meet that group of individuals. But when they get cognitive impairment that's too high of a level, most of these programs require people to be cognitively intact in order for them to really get have the ability to learn what we're going to be teaching or talking with them about, because they're not didactic programs. So it's not like there's a person, a teacher talking down to somebody. They're really group explorations. So what do I mean by an evidence-based program? And basically what that means in this particular case is that they've gone through extensive research, that there's measurable outcomes, and that they achieve specific goals. They're clear, structured programs. They all have curriculum that the leaders have to stay within fidelity and follow that curriculum. They've been peer-reviewed and published in peer-reviewed journals, and they're endorsed by a federal agency. And they're replicable, and that's a really key component, is all of them have gone through translation. Once the initial research has been completed, they've gone through translational research, and they've been spread into a number of different types of communities across the country and shown to have the same or equivalent outcomes. This slide just talks a little bit to the work we do specifically in this department. We provide exercise programs, all evidence-based, chronic disease self-management programs, and fall prevention programs. We do about 250 workshops a year across the county of Los Angeles. In 2018, we had 172 partnering sites that we worked with. We have 17 full-time employees and about 19 volunteers. We've been working really hard on our volunteer program so that we can increase our spread of the programs without adding additional cost. All of these programs are primarily funded by taxpayer dollars. So we have Older American Act 3D dollars from the city and the county of Los Angeles. We have 2 grants at this time from the Administration for Community Living, and some monies that come out of the Affordable Care Act, or Obamacare. We have a contract with a number of managed care plans, including Blue Shield of California, Promise Health Plan, and LA Care. And then we have some private foundation grants that also help to support the work that we do. The first program I'm going to talk to you about is the Chronic Disease Self-Management Program, and it's really a suite of programs. Here at Partners, we do the base program, which is the Chronic Disease Self-Management Program, in both English and in Spanish. That can be provided in person, online, or through a toolkit, and we use this 3-mode way of delivering the program for our Blue Shield of California contract. We offer each person that we talk with any of these 3 types of ways of participating, and it's really up to them what their preference is. We also do the Diabetes Self-Management Program, both in English and Spanish, and the Pain Self-Management Program. And this program was initially developed at Stanford University at the leadership of Dr. Kate Lorig. It's now been transferred to the Self-Management Resource Center, where Dr. Lorig works in her quote-unquote retirement. So the Chronic Disease Self-Management Education suite of programs, they're all basically set in the same way. They just have different emphasis. depending upon the particular disease state that the program is addressing. They have 12 to 16 participants. They're led by 2 trained leaders, and they're usually lay leaders. There's actually a strong preference for lay leaders when people that at least one of them also have a chronic condition that they're dealing with themselves, so that they can have empathy with the people that they're working with and really understand what it is to live with a chronic condition. Each workshop meets for 6 weeks, 2.5 hours a week. It includes group discussions, activities, and short lectures. And there's a book, which you can see here, called Living a Healthy Life with Chronic Conditions. And this book has been updated a number of times. I actually remember my mom having this book over 25 years ago. So Dr. Lorig has been spreading her program both across the United States and across health systems all over the world. So this program has been very, very well researched. Some of the things that we touch on are how important physical activity is, how important it is that people use their medications in the way prescribed by their physician. We go through some decision-making processes, and then one of the really key components to all of these programs is action planning and helping people understand how important it is to make small incremental goals that are achievable so that they can have success and then move on to another incremental goal after they've achieved that first one. And that is a key in all the literature to being able to make behavioral changes, is being able to make small incremental goals that you can achieve and feel good about. We go through some pieces about understanding your own emotions and being able to change your mindset. We do a number of problem-solving exercises where we use the group to help come up with ideas, and then the individual will pick which one of those ideas works best for them at that particular moment in time. We talk about how important sleep is. We do a piece on communication with your providers, your caregivers, and your family. Talk about healthy eating, and clearly in the diabetes workshop, the healthy eating takes a much larger piece of the workshop than it does perhaps in the chronic disease self-management program. We do a little bit on weight management and working with healthcare professionals. And this is basically what a class looks like. You can see the gentleman in the white shirt with the dark hair. He's one of our lay leaders, and this is a community of people that are participating in the program. And the outcomes from this program have been, well documented in a number of different studies, but this is one study from a union here in Southern California, where they did the chronic disease self-management program, and they were working with a managed care organization so they could get outcomes data. And it showed that in this group, after 12 months from baseline, so the outcomes held for a 12-month period after the folks went through the workshop, their self-rated health went up to 60% from 32% at baseline. Their body mass went down 1 point, and their A1C went down 1 point. Their blood pressure went down 11 points. Depression scores decreased significantly, and reported pain decreased significantly. And at the same time, the amount of exercise per week went up, and their strength exercises and stretching also went up. Since then, this union has actually taken the program and spread it to all of their organization across the United States. These are 2 studies, one for the diabetes self-management program and excuse me, and the other for the pain self-management program. And the diabetes self-management program, it shows that HbA1c decreased significantly, as much as you would expect it to if the person had started on metformin, and it also increased or had a positive effect on depression, hypoglycemia, adherence to medications, and minutes of exercise. And for the pain study, it shows that the folks that participated had an improved confidence in keeping certain symptoms from interfering with what they wanted to do. So they had less fatigue, less physical discomfort, and less emotional stress. So positive outcomes all across. Then A Matter of Balance is another one of the programs that is offered in many communities and through partners. Matter of Balance is a falls prevention program. And it's a program that acknowledges that there is a risk of falling, but emphasizes coping strategies to reduce fear. One of the key indicators for a fall is a fear of falling. So this program promotes a view of falls as preventable and controllable. It sets realistic goals for increasing activity. There is, starting in session 3 of this 8-week workshop, they start doing some light physical activities, physical exercises. It talks about what you need to know, an older adult needs to do to change their environment to make it safer for them. Moving area rugs, moving, extension cords to make sure that you don't have any trip problems in your home. And then it promotes exercise to increase strength and balance. Another falls prevention program is the Tai Chi for Arthritis program that's led by certified instructors. There's a warm-up and cool-down exercises. They progressively learn more advanced movements. They start with some 6 core movements and then move into 6 advanced movements. They also learn breathing techniques and Tai Chi principles to improve physical and mental well-being. This class is 1 hour for a minimum of 8 weeks. There's the Arthritis Foundation exercise program, which works on range of motion exercises, endurance building activities, provides also a discussion and practice and relaxation techniques. And then each class, there's a period of time either at the beginning or at the end where there's a little health education topic that's discussed. And this class meets twice a week for 1 hour for 12 weeks. There's the Arthritis Foundation Walk with Ease program, and that's a community-based walking program that meets 3 times a week for 6 weeks. And in this one, there's a pre-walk discussion covering a specified topic related to exercise and arthritis. And it generally is, people go for a walk for 10 to 40 minutes. And then we always do celebrations at the end of any of these workshops. And this is one of our workshops that was in a Latino community. A lot of the folks, at least in the Medicaid population that we work with, they haven't necessarily had a lot of celebration or graduation type celebrations. So we always do a graduation. We try to bring some food in so that people can have a little party with each other, because we feel pretty strongly that not only are these programs, and it's not only we feel, but there's been research to show this, and we're hoping, right now we're waiting to hear about a grant where we'd like to be able to provide some more proof that these programs really do, because of the sharing that goes on in them, talking about things that are more personal than what folks might talk about. When you start opening up about your chronic condition, you really start to empathize with those around you and see that there's things in common that you have to share. And there's, at this time, there's also a lot in the media about social isolation and loneliness, and how basically in terms of health, it's about equivalent. If you're socially isolated or have a long-standing feeling of loneliness, it's about equivalent to smoking 15 cigarettes a day in terms of what it can do to your health. So we feel that these programs really help with that social isolation and loneliness as well. And here are some participant testimonials about the workshops. The workshop put me back in charge of my life, and I feel great. I'm not alone, so they're speaking to that social isolation and loneliness piece. It helps me be more conscious of my emotions. I'm meditating now. So when we talk about communicating with providers and family members, clearly if we're more conscious of our emotions, more in control of our emotions, we're probably going to have better communications. And then finally, from this individual who had Parkinson's disease over the past 20 years and had a great deal of suffering from depression, it says, the skills you've taught me in maintaining positive thinking and combating depression have really helped. So, you know, I've actually led these workshops, and I've heard the stories of people and how great the effect can really be on their day-to-day lives. So not only do we have, you know, the outcome of being able to hopefully, and, you know, if you saw those HbA1c scores going down, and if you look at the long-term research, the return on investment, the financial positive effects of the programs, but there's also the personal and psychological positive effects that the programs have. So how can you refer people into these programs? There's a website called the California Healthier Living website, and California Healthier Living Coalition is a coalition that was started by partners in Dignity Health in the California Department of Aging and Kaiser Permanente. It was probably about 10 years ago. We come together every year. And we have, in November every year, we have a conference where we come together, and it's a number of organizations that do this work and support these programs. But on the website, you can actually go and refer folks into any one of these different types of evidence-based programs. So down in the left-hand corner there, you can see the web address. So how do you make a referral? So you want to be able to collect some information from the person you're working with first. You need to know what kind of program they're interested in. You need to know their zip code, and you need to know approximately how far they're willing to travel to participate into a workshop. And then if you go to that website, the healthierliving.org website, California Healthier Living website, you can put either the county or the zip code in where you see them here, and then the area in which the person is willing to travel, so the radius in miles, and you'll see that the little pins pop up like this, and then if you hover over the pin, you can see what kind of workshop it is. And then you can go to the actual description of the workshop, and it shows where it's located, the address, the dates that the workshop will be going on. And then you can go over to this read more and put in the information about the person that you're referring. So you can put in their name, if they will let you, their email address or phone number, and then any additional information that you'd like to provide. And we can reach back out to them, staff here, partners can reach back out to them and put them into a workshop. Now, this is just obviously for folks in California, but every county in California does put information about the workshops that they do onto this Healthier Living website. So it's a pretty great resource for you to see who in your community is providing these programs, how widely they're provided, and to refer people into them. that's my part.
Thank you so much, Diane. That presentation really provided excellent insight into social determinants and really how Partners in Care is helping to move the needle with this work. So we definitely appreciate you sharing your knowledge and work with us today. And as previously mentioned, CE credits will be emailed within 5 to 7 business days for those of you who registered as healthcare professionals. So if you don't see that in your email, please be sure to check your spam folder as well. Next slide, please. And if you enjoyed today's webinar, Shield Healthcare offers more useful information via our online community. Our site is geared toward healthcare professionals, patients, family members, and caregivers. So please feel free to check out our community site at shieldhealthcare.com/community. And for past and upcoming webinars, our webinar site is shieldhealthcare.com/webinars. Next slide, please. As you see here, we also have an array of free educational booklets that align with the products we supply, such as ostomy, wound, enteral nutrition, incontinence, and urological, as well as guides for aging safely at home. So if you'd like us to send you a guide, please just go to shieldhealthcare.com/community to request one. Next slide. And here we have Diane Davis's contact information in case you would like to follow up with her directly. So I'll go ahead and give you a moment if you'd like to write that down.
And Kelsey, I guess I also wondered, were there any questions or?
Yes, we'll be following up with questions just after our next slide.
Okay.
We can go to the next slide. And if there are any additional questions about the presentation, below is the contact information for the respective parties. So we have Shield Healthcare, Partners in Care Foundation, as well as Capital Nursing, who will handle the CE credits. And now we will open it up for our questions. We've had some good ones come in. So I will go ahead and start with Diane. Are there programs to assess risks/help individuals in early stage of dementia? And if there are, please provide examples.
So there's a program that is been put together by UCLA Memory Program, and it's not really for people in early stages of dementia, but it's to learn skills to help increase one's memory. So I want to be careful. I don't, as far as I know, there aren't any specific programs that stop the progression of dementia or, are really for people that have full-on dementia. But for people who are just older, and, we all know that memory isn't as good. I know, that's for sure, that memory isn't as good as one ages. For folks that have some concern around that and want to learn some tools to help them with their memory, the UCLA Memory Program is a good one.
Okay, thank you. Next question is, how does the medical system deal with a trigger event after discharge or once a patient is back home?
So I think, if you know a medical system, you know a medical system. So I think, I don't think there's one way that all systems operate by any means. But if more and more large healthcare systems and managed care plans are having population health departments, and in those population health departments, they really do surveillance on things like trigger events. For instance, they might look at pharmacy data and, on a monthly basis, they may look at individuals who have had a change in the medication that's being prescribed for them. And I'm not a pharmacist, so I don't know exactly what those medications would be, but if they get moved from one medication to a higher level medication, for instance, they go from taking a pill for diabetes to becoming insulin dependent, that would be considered a trigger event, and that would show up in the pharmacy data. And so they might have a case manager then reach out to that person when they've had that change in the criticalness of their disease, and talk to them about diabetes education, or talk to them about going to a diabetes self-management program. In terms of a discharge, every system is going to handle that differently. I think some systems are working with community-based organizations like Partners to go in and do that care management piece right after discharge, to go into the patient's home, take a look, make sure they have food in the refrigerator, that they've got air conditioning if they live in a place that's has extreme heat like we do here in the San Fernando Valley. Make sure that that person gets connected back to their primary care physician, and does a check on the medications to make sure that they haven't been prescribed on discharge a medication that they already are taking at home, or that there isn't an interaction between some over-the-counter medication that they're taking and some newly prescribed medication. So again, I'm not sure that unfortunately, we don't live in a country or in a society where every system operates in the same way. But the best practice, I would say, certainly is that there be that kind of follow-up after someone's discharged.
Okay, great, thank you. And our next question is, do the healthcare systems tend to have funding to share with CBOs to assist with some of the higher risk groups?
I think that as the incentives are changing, incentives for large hospital systems now are that if they have, for certain diagnoses, if they have folks that are readmitted within 30 days, that they aren't going to be paid anymore for that readmission. So the incentives have changed enough. And in medical practices, if they don't meet certain quality measures, their reimbursement, they're going to lose out on some reimbursement. So as these incentives change in the system, there's more of an incentive to begin to work with community-based organizations to do these types of initiatives. I'm not going to say that it's easy. And my boss, June Simmons, always says, no is just a longer conversation. So I think, we can't think that because we've been turned down a year ago that the circumstances aren't going to have changed. New people come in, old people leave, and you have to keep those conversations going on and really stay open and stay positive. But certainly the incentives are much more aligned now for those systems to work with community-based organizations than they have been in the past.
Great. I think that's a really powerful message as well. Our next question is, how can we get these types of programs into other states or communities?
So I think that many people would be surprised at how many states and communities they are in. It's just, unfortunately, even though there's funding through Administration for Community Living and Older American Act dollars, it's equivalent to about 40 or 50 cents per person 65 and older. So clearly that is not enough funding to spread them, like June has said before, she'd like to see them be like fluoride in the water. So I think what you have to do is you can go to the Evidence-Based Leadership Collaborative website, EBLC website, and they have we have on the Healthier Living website a program finder mapping for California. On the EBLC website, they have one for the nation. I would go to that website and take a look. I'd call your AAA in your area or your senior center to find out if they do these evidence-based programs, because most communities across the country, the 3D dollars out of the Older American Act can only be used now for evidence-based programs. So that means that they should be done in some way in all communities. Now, finding out about them and having them advertised is a different story. But I think between that Evidence-Based Leadership Collaborative site and talking to your senior centers or your area agency on aging, you should be able to find them.
Thank you. And our last question is Partners in Care planning on replicating this program in other states?
No. I think California is probably big enough for us. But I will say that we are a leader nationally, sort of in the movement of bringing these types of evidence-based programs to communities. I work on the National Council on Aging's Network Development Learning Collaborative, which is a mentoring program for community-based organizations that want to join together in hubs to provide all of these types of programs that Partners provides throughout their states. So, National Council on Aging is a good organization to look to. I think also N4A, which is the organization of AAAs. It's a national organization representing AAAs. Partners works very closely with them on mentoring and sort of teaching organizations how to work with healthcare systems. So there's a number of different national organizations that are interested in CBOs coming together, working together in hubs, and being able to contract with managed care organizations or with large health systems. And I think if you go to the NCOA site or the N4A site, you will be able to find information about this.
Perfect. Well, thank you so much for answering those questions. It looks like we're finishing right on time today, so we appreciate everyone who has come on to view this webinar, and a big thank you again to Diane for being our wonderful presenter. So that is all for today, so we hope everyone has a great rest of their day.
Great. Thank you so much.
Thank you.